Thanks very much. We're going to talk about an introduction to stress testing. And I do have a question. So I'll ask Mahmoud, do you know why I called this stress testing 101? Why did I put 101 in there?
Yeah, hi, doctor. I mean, I don't know why.
Okay, Manish, do you know why?
I haven't had my coffee yet, so I have no idea.
Okay, so actually I did this on purpose, and it's because for those of you who, and it's more to cultural information. So it turns out if you go to university or college in the United States, every single introductory college course is 101. So if, like, for example, if I signed up to take a course to learn Hindi, it would be called Hindi 101 or Spanish 101 or Mathematics 101. So the first semester would be in college would be, 101 level course, second semester 102. Then you get into the upper class, it would be 201, 202, and then the upper level in graduate would be 301, 302. So I just wanted to point that out for those of you who didn't go to university in the United States. That's all. All right, so let's go on. So this is stress testing 101, but most of you are in advance of this. Here's the question. I'm going to ask you some of them, and don't worry, I'm not trying to put anybody on the spot. I'm more for educational purposes. You guys are very smart and just haven't, you're just starting cardiology, so don't worry about it. I'm not trying to show anybody up. So first, this is a pre-test question. This is an active 70-year-old man. He comes in with exertional chest pain that sounds like angina, but you're not sure. There's some atypical features. His physical exam is normal, except for a paradoxical splitting of the second sound. And why? Because his ECG shows a left bundle branch block, and you do a previous EKG, you look at a previous one from a couple of years ago, and it's unchanged. But a couple of years ago, he didn't have his chest discomfort. He can walk on the treadmill. I mean, he's able to walk. He does that for exercise. So the question is, Manish, what stress test would you order to you didn't have your coffee yet. Are you drinking coffee? But never mind. I don't want to ask you that. But so what test below should you order to assess for coronary disease? You want to do a stress test. And those are the choices: a regular exercise treadmill test, an exercise nuclear scan, or a Lexi scan.
I mean, he can exercise, so I'll do a nuclear stress test, the exercise one.
Okay, I'll take that as your final answer. So it's actually not correct, but this was a pre-test, so you're not expected to know the answer to that. We'll come back to that in a second. We will come back to that. So in to look ahead, basically in a patient, if you're looking for the ECG, if a patient has a left bundle branch block, ECG diagnosis on stress testing is pretty useless. Same for ischemia, and it's very difficult in the setting of acute MI, but we'll talk about it a little more later. So what are the indications for stress testing? Shown here, diagnosis of coronary disease in patients with chest pain. That's what we're doing it for this 70-year-old patient. So there are other indications. It's not only for that. Risk stratification and prognosis in coronary disease and suspected CAD. So if you know that someone has CAD and you want to know what his or her limitation is, stress testing can help sometimes. Determine functional capacity and response to therapy in patients with cardiac and pulmonary disease. And as you know, for transplant evaluation, we look for, we do a cardiorespiratory exercise test to see what their maximal oxygen uptake is. And therapeutic decision-making, those are the major things. Another one I had recently is a 85-year-old man who's fairly active and he gets short of breath with exertion. His heart rate is relatively slow. It's in the 50s. Does he have sinus node dysfunction? Can he increase his heart rate with exercise? Sometimes you can do that informally, but if you're not able to do that, exercise testing can be useful to see what his heart rate response. That's what the first thing that Pickett or Schmidt's going to ask you when you have a patient, you refer them for potential pacemaker. Okay, so is this a safe test? Is exercise stress testing or any stress testing safe? And the answer is pretty much yes. These are the published data. And by the way, the ACC-AHA guidelines are not really that modern. The last one was updated in 1997, and then there was a brief update in the early 2000s, but this is still not really like the latest guidelines from last year. These are pretty old, but they're, there's not tons have changed. So the risk of death from these tests is about 1 in 2,500, same with risk of MI. And there are other complications that we see. We see cardiac arrhythmias. Patients can develop AFib, which can stay on for a while or sort of persistent, VT, SVT, and other arrhythmias. Patients can get hypotensive. They can get unstable angina. They can trigger plaque rupture. And there are other ones, but those are the main complications, and they can die. We actually, about 20 years ago, before the thrombolytic, just as the origin of the thrombolytic era and before the PCI era, we had a patient doing a low-level stress test after MI, which we were doing to look for inducible ischemia, and the patient actually died on the treadmill. But anyway, okay, so some factors in stress testing. These are the important factors. So there's the, and I'm going to introduce these topics because there's a lot to cover, but I will talk about them, but everybody should be familiar or gain familiarity with the concepts of sensitivity, specificity, and predictive accuracy of the test. The cost of the test relative to other testing modalities, of course, exercise stress testing is the lowest cost. Nuclear scanning adds quite a bit of cost to that. And by the way, Medicare and Medicaid are doing an audit on many hospitals, or pretty much most hospitals, I believe, around the country, about the performance of testing to make sure that the indication is correct and the reporting is correct. And the safety is correct and the timeliness, et cetera. So actually, they stopped temporarily during the COVID pandemic, but we get, we've had like 7, they're going to look at 100 tests at most hospitals. We've gotten 7 so far from ours. Fortunately, we're 7 for 7, but all of our nuclear stress tests are being audited by the feds for appropriateness, appropriate use criteria, and I will go into that in a little bit later. So the other thing is the effect of a positive or a negative stress test on therapeutic decision making. I'm going to ask you a question about that in a minute, and the potential for psychologic benefits and patient reassurance. So sometimes we know that patients don't have CAD. You have a patient comes into your office like every month. I think each of us has one of these patients in the clinic. Atypical chest pain. There's point tenderness. We know it's not cardiac, but the patient is EKG is normal and everything. The patient's driven bonkers by this. So sometimes, in the right setting, if we do a stress test and it's normal, there does appear to be some degree of reassurance. But be aware, Mahmoud, I'll ask you this question. So let's say you have a 25-year-old woman with no symptoms, with no cardiac symptoms, no chest pain, and her father, let's say, died of acute myocardial infarction, and she comes to see you and she says, I want a stress test because I'm afraid, I have a family history. You say, do you have symptoms? No symptoms. And you do a stress test and you get 2 millimeters of ST segment depression. So in strict terms, this is a positive test. What is the likelihood of coronary disease in that 25-year-old woman with a so-called positive stress test? What's your sense of the likelihood of coronary? You've no symptoms, you've done the test is abnormal with 2 millimeters of ST segment depression. What's the likelihood of coronary disease in that patient?
I mean, I'm going to guess that the likelihood is low because the pre-test probability was low.
Absolutely. Excellent. That's right. That's exactly right. So I've done the numbers on these pages. The probability of coronary disease is less than 20%, very low. So the bottom line is, and I'll come back to this a little bit later, bottom line is in a patient with no symptoms, this test is most useful in patients with some symptoms. It's not very useful in a patient without symptoms. We'll come back more of that later. Good answer. Okay, so what is considered an ischemic response? So ischemic response is considered to be 1 millimeter on an ECG test, 1 millimeter of horizontal or downsloping ST segment depression with exertion. And a couple of points about that. Number one is that recovery, if you see those changes in recovery, so let's say that the patient exercises and you don't see any ST depression during exercise, but the patient rests, stops exercising, and about a minute into recovery, you get ST segment depression. Those tests are similar in diagnostic accuracy to any change that occurs during the exercise phase. The reason for that is the following, especially if you're kind of want to induce ischemia and they're borderline ST changes, you take the patient, you lie them down on the treadmill and you can get the legs up. What happens is, remember the determinants of myocardial oxygen demand are heart rate, contractility, and wall tension. And wall tension by Laplace's relationship is equal to pressure times the left ventricular pressure times left ventricular radius divided by wall thickness. So when you lie someone down, what are you doing to LV radius? You're increasing it because there's central pooling, blood comes into the central circulation, the left ventricle expands a little bit, and you get higher myocardial oxygen demand because of the size of the left ventricle. So that can induce ischemia. It can offset the supply demand, upset the cart, that balance beam that you all know about, and cause more myocardial demand, and it sets supply and demand out of balance, and that will lead to myocardial ischemia. So changes in recovery, same diagnostic accuracy as changes during exertion. A couple of other points. The location of the ST depression is not all that helpful. So if you see ST depression in the inferior leads alone, doesn't mean, there's only about a 50-50 chance roughly that the ischemia is going to be in the right coronary artery or in the dominant circ. So the location of the ST depression not helpful. The extent of the ST depression is helpful in the sense that the more leads that you see ST depression, the longer the ST depression occurs, the greater the level of ischemia, the more likely for multivessel coronary disease. And as I pointed out a moment ago, the duration of the ST segments is important. Longer duration into recovery, I just said that, multiple leads. Now the other point is that if you only see ST depression just at peak exercise and it resolves by 10 seconds, 20 seconds, or even a minute in recovery, that is often a false positive. It's also likely a false positive, especially in the inferior leads. So you can often see ST depression in the inferior leads at peak exercise that go away immediately. Bingo, it's probably a false positive. Probably a false positive. Okay, so we will, let's see who we got here. Okay, Shiv, I will ask you this one. Oh, actually, yeah, the answer is given there, so that's too easy. I gave you the answer on the screen. So this is an example of a typical ischemic response on treadmill testing. The baseline ECG is shown on the left side. You see in V5 and V6 that there is normal ST segments, and this is a classic ischemic response that occurred in recovery. Downsloping ST segment depression that lasts long into recovery. This is present actually in all the precordial leads. It's present in V2, V3, V4. There's another finding here which we will go into. And I'm just pointing out here. Look at that ST elevation in V1. So I'll give you a softball across the plate, John. So what do you expect to see at cardiac cath, John?
Obstructive coronary artery disease.
Yeah, correct. In which vessel?
LAD territory.
Yeah, possibly proximal LAD. We'll talk more about that. But the ST elevation in V1 should send shivers down our spines, because that's a very ominous sign, either left main or proximal LAD.
Dr. Schulman, I was going to mention there's a PVC as well at the start, and I guess maybe we'll talk about it later too.
Yes. So so it's a good point. The presence, I'm not going to go into that a lot, but the presence of PVCs in the setting of ischemia is often felt to be an adverse prognostic factor. It's not so much in a patient without ischemia. You will see a lot of PVCs. You'll see a number of patients with PVCs and PACs during exercise, and that's not that concerning in the absence of ischemia. But good pickup, John. Very good pickup.
Thank you.
Okay, so here is another one. Let's see who we got here. Justice, have you had your coffee this morning? Maybe not.
Hi.
Okay, you had your coffee. So anything you see on this? This is a patient with some concerning chest pain. So stress testing was done. You want to delve into this one a little bit? What do you see? Any concerning findings? So the top is resting. I said there. Bottom is.
I can't see the rest of the bottom, but it looks like V3 has ST elevations. The rest of the leads, what I see is mostly upsloping depressions.
Okay, good pickup. V3 does have ST elevation, but also look up at V. Now, interestingly, this is not a great tracing in V2, so it's up and down, but look at V1. Compare the baseline. Look at the J point. Are you familiar with the J point?
Yeah.
The J point is the part of the ECG between the end of the QRS and the ST segment. Yeah. And you see the J point in the resting tracing is at baseline, and the J point of the stress ECG is about 1 millimeter elevated. So this, you saw it correctly in V3. So ST elevation V1, V2, V3, very concerning for proximal LAD disease and or left main disease, and that's this patient had fairly proximal LAD stenosis. And as you pointed out, Justice, the other leads are not that concerning. One other, I think I point this out later, but it may come up later, but you can often see, because AVR is a lead that's in a similar electrical vector as V1, it's not that far off. You can sometimes see ST elevation in AVR. If you see it in isolation, it's not as concerning. It does occur. It can be a sign of prox LAD disease or a left main, but alone it's less specific. It's not as concerning. So people will point that out, but that alone, ST elevation in AVR is probably not, if there's nothing else going on, probably not too much to worry about. It can occur in normals. Okay, so we talked about that. Exercise ST elevation could reflect transmural ischemia, so it could be a bad marker of patients with multivessel coronary disease or severe ischemia. Let's say that 99% stenosis that you uncover during stress testing. So transmural ischemia. Coronary artery spasm, there are patients with exercise-induced spasm, but it often reflects severe coronary disease. We talked about the ST elevation in AVR alone. We talked about ST elevation in V1. So it's got a ST elevation V1, it's got a greater than 70% positive predictive value for proximal LAD, or 60, I think is probably a better term. I've seen articles with 60 and 70. Okay, so let's talk about some confounders, some confusers of ST segment depression. We don't use digitalis very much anymore. I just actually put someone on digitalis yesterday for rate control, couldn't tolerate more beta blocker or DILT, but there's a very high false positive rate. If you see a patient on digitalis and you see ST depression on the EKG, very high false positive rate. Now beta blockers, so that's a false positive rate. Beta blockers, interestingly, is a drug that will reduce the sensitivity, and that makes pretty good sense because it actually treats ischemia. So if you're looking for the diagnosis of coronary disease, you're not sure whether or not a patient has coronary disease, you probably want to take the patient off the beta blocker to allow ischemia to occur if it's there. Because if you put the patient on the beta blocker, you're going to probably be treating the ischemia. Now, the other thing about that is if you have a patient with known coronary disease and is already beta blocked on nitrates on decent anti-ischemic therapy, and they come to your office and they say, you know what, I'm having chest pain. Well, they're having chest pain on their therapy. So in those cases, I generally recommend that you continue the patient on the beta blocker and whatever else they're on. The reason being is you're not asking the question if they have coronary disease. You're asking the question is they do have coronary disease, known CAD, is their chest pain ischemic or not? And in that case, you want to continue the therapy because that's what their baseline status is. You know, other people say, well, you're reducing the sensitivity. Yeah, well, you're not trying to do this test to determine the presence of coronary disease. You're doing the test for a different reason. Known CAD is this ischemic chest pain. And of course, then other anti-anginals also reduce the sensitivity of the test to detect ischemia. Again, for whatever reason you're doing the test, then you make the decision whether or not to continue the therapy. The next point I've already made, in a patient with left bundle branch block, you really cannot evaluate the ST segments. It's not like MI where you can use the criteria, I'm blanking on the name, but you can use the criteria, someone refresh my memory here for acute MI.
Criteria.
Pardon me, yeah, say that again?
Scarbosis criteria?
Yes. Mm-hmm. Yes, so there are criteria in a left bundle for MI, but in stress testing, as they say in my native country and my native language, forget about it. You can't really use the ECG alone to detect ischemia. Right bundle branch block, you can. If a patient has a right bundle branch block and their baseline ST segments are usually abnormal in V1 through V3, sometimes V4, but if their baseline is okay in those leads, you can do a stress test. You can't really use those leads V1 through V3 or V1 through V4 to detect ischemia or to assess for ischemia, but the other leads are fine. One AVL, inferior leads V5 and V6, sometimes V4. That's okay. And then there's left ventricular hypertrophy. So if a patient has known LVH or has an ECG that suggests LVH, there is a high chance of a false positive in the stress ECG. So be very careful there. Some people have written that if there's 2 millimeters of ST depression, or you need 2 millimeters of ST depression to make the diagnosis or to assess for ischemia, that's one thing. Other people say be real careful about that. On the other hand, if the stress test is normal and you don't see ST depression, it's pretty good specificity in that case. So if a normal test probably indicates is high chance of no CAD, but just be aware of the left ventricular hypertrophy. And then there's resting ST depression. There's a lot of debate about that. If a patient has less than 1 millimeter of resting ST depression, you can use the stress test. And what you do is you look for additional 1 or 2 millimeters of ST depression. So but if it's really an ugly ST depression at baseline, downsloping 1.5 millimeters, 2 millimeters of ST depression, probably stress testing is not, exercise ECG is not the best stress test to do.
Dr. Schulman, I have a
Yeah.
quick question, please.
Yes.
So there is this was confusing to me when I was starting my fellowship, and I'm maybe confusing to some of the fellows, why we choose not to do exercise in left bundle. And I'm talking only here about diagnosis, not functional assessment. There is also a reason to use only vasodilator with nuclear. What's your comment on that? Why not to do like exercise with nuclear or exercise with echo or something like that?
Okay, good question. So in a left bundle branch block, you cannot evaluate ST segments. I'm going to come back to that in a minute. LBBB is a different issue. You can't even use an exercise nuclear stress test with a left bundle branch block. You're sort of anticipating my later slide. You cannot use a left bundle. You can't use exercise ECG. You should not use a nuclear exercise test with a left bundle branch block. Now you ask why you should not just go right to exercise nuclear or vasodilator test. The reason being is that number one, you're going to get dinged by, it's actually not in the appropriate use criteria to do that. Appropriate use for cost benefit analysis. The stress ECG is the first test we should be using. And the reason being is that many tests you will get the answer right off the bat, and you'll be saving the extra $1,000 that's needed for the addition of a nuclear or a stress echo. So you're right, you may have a higher risk of a false negative or a false positive, but if you get a good stress result with a regular exercise stress test, you're pretty much done. The sensitivity and specificity and positive and negative predictive accuracy are reasonable. They're not always correct. You're right that you're going to get some. I'm going to come back to that point in a minute or in a little bit. But basically, it would be, if there's no cost difference, that your point would be well taken. But in the era of cost savings, we don't do it that way largely for cost saving reasons. And I'll give you a little more information on that in a couple of minutes. Okay, I'm not going to go into this in detail, but you can use the Duke Treadmill score. It's on your phone or QX calculator or any of those things. There is a Duke Treadmill score in patients with no known CAD. This is for patients without, if you have known CAD, you can't do this. But basically, it's a function of exercise time. It's a function of chest pain during exertion, and it's a function of ST segment depression during exertion. There are some imperfect, and then it gives you a risk score from high risk -11, which indicates a 5-year survival of 65%, and then et cetera, et cetera. So basically, it's useful to use if you're pretty sure the for example, if a patient could go 16 minutes on the Bruce protocol and has a millimeter of ST depression at the end of exercise and nothing more, that's a very low risk stress test because of the high duration of testing. There are some drawbacks to the Duke Treadmill score. For example, this issue of the very brief inferior ST depression at peak exercise only, that kind of sets this off a little bit because you'll get an ST segment, you'll get a detriment from the ST segment depression. So there are pitfalls for this. It's a relatively old score, but it's still relatively useful to be familiar with. I don't think you have to memorize it, but so you take the exercise time in minutes. Let's say the patient exercised 14 minutes. You subtract 5 times the ST deviation in millimeters. So you subtract, so if the patient has 1 millimeter of ST depression, that gives you a score of +11, which is still a very good score. If there's no chest pain, the score is +11, and that's a pretty good score for this. I'm not going to go into all the details. I'll let you look at it, but at some point you want to take a look at the Duke Treadmill score for patients without CAD to look at the it doesn't really give you a probability of disease. It gives you high, medium, or high, intermediate, or low risk status. And then this was way before the high PCI, the high levels of PCI. We weren't doing PCIs when this Duke Treadmill score was formulated. Now, the other thing I'm going to talk about briefly, I'm not going to go, you could spend a whole lecture on this. You guys should have some familiarity with Bayes' theorem. It's very interesting. I wrote an article on this, a book chapter that's fairly simple, so I can understand it more than 40 years ago. But Thomas Bayes was an interesting guy. He was actually an English theologian. He was a clergyman, and he was a mathematician. He dabbled on the side. And notice his years of life. He lived from 1702 to 1761. And we now use Bayes' theorem for almost every clinical decision making that we do in medicine. Notice when his famous article was published in 1763. It published after he died. A very humble guy. Very humble guy, just like our commander-in-chief. Never mind. He has his article starts out, or the prelude to his article, which is published in some British journal, that I have a mathematical solution for this problem, but it's much too long and intricate to be at all useful. To be practically or materially useful. It's interesting that he was a pretty humble guy, published 2 years after his death, but it's an extremely useful concept that he formulated when he was, when he was just sort of dabbling in mathematics when he was really a clergyman. So I'm going to go over a couple of things with you to be familiar with to get you started on this. If you're not familiar, many of you are. But remember, you should be familiar with the terms sensitivity and specificity. So the sensitivity of the test is the ability of the test to detect disease. So if you do a test on, if you're testing, let's say 50 patients, let's say you're testing 100 patients, all of whom have the disease, and you get a positive test in all of them, your sensitivity is 100%. If you get a positive test in 50 of them, your sensitivity is 50%. So that's the sensitivity, and it's in mathematical terms, it's the true positives over all patients with disease. So divided by true positives plus the false negatives. So that's the sensitivity of the test. And specificity of the test is the ability to detect normals, persons without disease. So, Mansoor, I got a question for you.
Sure.
So one of the first year fellows, you're supervising a first year fellow who's doing stress testing, and he did drink his coffee, and he did stress testing for a whole week, and he wasn't first of all, this never happened in our program. This would be a different program. Okay, this is an alternate world. So one of the fellows, Joe Bronkovitz, does stress testing, and something he just doesn't understand the concept, and every single test he writes as a positive abnormal test. He does 100 tests that week. Some patients probably have disease, other patients don't have disease, but every single test he writes abnormal test, positive stress test. So I'm going to ask you, what was the sensitivity of that stress lab that week that fellow did the stress testing, where he labeled every single one of them as a positive or abnormal test? What's the sensitivity of the lab that week?
So he would have a very low sensitivity because his false positive rate is high. So he will have also low specificity because his
No, I
flow,
just asked you,
the
I'll look up
sensitivity.
that. I just asked you about the sensitivity of the test. And there's, you can see the slide, the sense is the ability of the test to detect disease. So he read every single patient, every single test, 100 tests he did that week as positive or abnormal.
Yeah, so it's going to be low.
Okay, so look at the definition. So we don't know. So some patients have disease, some patients don't have the disease. What's the sensitivity?
Oh, I hear what you're saying. So he can cast a wide net. So he's going to be a very high sensitivity.
100%, exactly. 100% sensitivity.
Yes, got it.
Exactly. So be aware of these concepts. So now you were correct. The specificity sucks, but sorry, pardon my French. Pardon my language, but yes. So, all right. With that in mind, Shiv,
So
are
what
you
I
on the
learned is
line?
that coffee increases the sensitivity, increases the specificity.
Okay. So Shiv, are you on the line?
I am.
Okay. So next week we have another fellow at another program who basically does just the opposite. He didn't have his coffee. He doesn't know what he's doing. And he reads every single test, 100 tests for the week as normal, negative test. What's the specificity of that lab for that week?
He said everything was normal.
He said absolutely every test was normal. Puts that in the report.
Okay, and what did we expect the rate of true cases to be in that case?
So let's just say it's a normal cadre of patients. You know, some will probably have coronary disease, some don't. We don't know that, but this is a standard, stress lab during a week. We're always going to have some people with disease and some people without. But he didn't drink his coffee. He didn't drink his tea. He just said, the heck with it. And he reads every single test as normal for the week. My question is, what's the specificity of the lab that week?
100%?
Absolutely, 100%. But did we do any good for these patients? Absolutely not. So be aware of these concepts. Sensitivity, the ability of the test to detect patients with disease. So that first week, it was 100%, specificity sucked. And the second week, specificity is 100% because every single patient who didn't have disease was correctly identified. But it doesn't talk about the patients. I'm sorry, every single patient without disease was correctly identified as normal, but it doesn't say anything about the patients with disease. So those are just some concepts to think about when next time you have the opportunity, take a look at that. I'm not going to go into all the formula. It does make sense. You could do this by hand calculation. It's not that difficult, but do become familiar with the concept of sensitivity, specificity, and predictive accuracy. The predictive accuracy of a positive test is if you get a positive or abnormal test, what's the probability that your answer is correct? And the predictive value of a negative test is if you call it negative or normal, what's the probability that your result that you reported is correct? So those are 4 different concepts that you should become familiar with. And I'm not going to go, I'll be happy to talk more about it in person, but right now I want to move on. Let's go to what the rough sensitivity and specificity are of these tests. So they're pretty similar. So if you look at a normal regular exercise test that just involves exercise testing, the sensitivity is about 70%, the specificity is about 90%, and you do get a little bit of benefit with with some of these other tests. Dopamine echo is about 80 and 85. Nuclear stress test is about 85 and 95. So you do improve sensitivity and specificity by adding nuclear imaging or adding an imaging modality. And Mansour's question a couple minutes ago was good. Yes, you can improve sensitivity and specificity. Why not go right to it? It's mostly for the cost that you don't go right to these other tests. So the test accuracy depends upon the sensitivity of the test, the specificity of the test, and the pre-test likelihood of disease. We'll come back to that in a minute. Okay, so here are some factors that you should have some general familiarity with. Remember that the pre-test likelihood of disease, or the same as the prevalence of disease, depends on the age, depends on the type of chest pain, and those are some of the numbers shown there. There's a couple of articles back from the 80s that really haven't changed. This one was Diamond and Forrester. There's another one I'm blanking on, but Donald Weiner has another test, another article that was in New England Journal that shows that if a man 60 years old has, let's go at the bottom here, man who's 60 years old, who has typical angina on the lower right, the likelihood of disease is 95%. Do you need to do stress testing in that person to detect coronary disease? No, you don't. You're 95% sure that that person has CAD. Same with a 50-year-old man. You're about 90% sure. So in a patient with typical chest pain, you don't really need to do testing to make the diagnosis. You take the atypical chest pain in the middle category, and you're a little better off here. You have about a 50-50 chance in a man and about a 40% chance in a woman that it's truly coronary artery disease. But then again, you have an asymptomatic person. A woman who has no symptoms has about a 1% likelihood of disease, and a male has about a 5% likelihood of disease. That's why it is generally considered not very helpful to do stress testing on asymptomatic individuals. I'm going to come back to that. Oh yeah, here it is. So if you look at this curve, so this is the sensitivity and specificity. This is sort of like the post-test probability difference. So that's this. The banana curves are the. Well, let me show you this one in the middle. So what this tells you is that if the pretest likelihood of disease, let's say on the x-axis is 50%, and you don't do any testing, you basically draw a straight line from zero all the way up to the top of this banana, and you get the same pretest likelihood of disease as post-test. You get a 50% pretest and post-test if you don't do any testing. But if you do testing in this person with intermediate pretest likelihood of disease, if the test is positive, is abnormal, you go up here to over 80% likelihood of disease. And if it's abnormal, you go to over 80%. If it's normal, you go down here to a lower pretest likelihood. And this curve in the middle shows you the difference between the abnormal result and a normal result. So if you go to the extremes down the bottom, if you do a test on a patient with a very low pretest likelihood of disease, you're not going to get much bang for your buck. You're just going to go like sort of up here in this post-test probability difference curve. Same thing way up here. You're not going to get much of a difference between an abnormal test and a normal test. It's those patients in the middle of this pretest likelihood scale that show a very large probability difference between a normal test and an abnormal test. And this is the area here where you get the most diagnostic help in patients with coronary disease. High likelihood to start with. You're not doing much for the patient to get a stress test to diagnose disease. You got the disease already. You got this. You know you have it. So this is an important concept to remember. Now, this is I'm gonna skip this for now. So a couple other things to point out. This is important to know, to have a general sense of what patients need to do, what activities that at home require what amount of MET's metabolic equivalent. So 1 met is what we need to just basically sit here and use the bathroom and eat and get dressed, etc. And 4 mets is what's required to be able to do light housework around the house, to climb a flight of stairs or walk up a hill. The 6 mets is 6 mets is what it takes to walk up to walk up a flight of stairs with a bag of groceries and run a short distance. And you need 10 mets to do things like playing basketball, to go skiing, to play tennis. Let's see. So the other question, let's see who I can ask on this one. Okay, Rohan, I got a question for you. So your patient, you have a clinic patient who has a new boyfriend or a new girlfriend. He had an MI 10 days ago. He asked you if he can have sexual relations. What do you tell him? And where does sexual activity fit on the chart below?
You would tell him that that's okay as long as he doesn't have any symptoms. But if he does have symptoms of angina, then he should refrain. Right.
Okay. And where does sexual activity? And I'm asking you this. I'm not trying to. I mean, I'm just because patients ask you this. You guys should know the answer. You folks should know the answer to this. So where does sexual activity fit on this metabolic equivalent chart? Is it 1 met? Is it 10 mets?
1 to 4.
Well, it's actually around 4 to 5 to 6. It's right about in here. So if they can do light housework and climb up a flight of stairs, that usually indicates that they can partake of sexual activity. That's around there. And that, by the way, is what it takes to go through elective surgery. Same thing, surgery, sexual activity, etc. Basically walking up a flight of stairs with a bag of groceries. Correct. Now, we're gonna skip that for now. So this is relates to Mansour's question of a few minutes ago. So there is, I'm not going to go into all these, but there is actually an appropriate use criteria for nuclear stress testing. And actually, this is what Medicare, what CMS is doing, the Committee for Medicare and Medicaid Services, and they will actually. If you order inappropriate stress tests, if you do it too much, you will have to pre-certify by phone every single stress test that you do. So basically, I'll just pick a couple of these out. This is an appropriate use for nuclear stress testing if a patient has a low pretest probability of CAD, if the ECG is interpretable, and if the patient's able to exercise. The appropriate use score is 3, and that's therefore an inappropriate use of nuclear stress testing. On the other hand, if the patient has an ECG that's uninterpretable or unable to exercise, that is an appropriate use of stress testing with nuclear imaging. So there is, Mansour, a appropriate use criteria. You're probably familiar with these, and it's important to have some familiarity with these when you're ordering stress tests, because Medicare is going to monitor these, and you will be on their bad list for Santa Claus won't give you a present. Doesn't bring me a present either, but that's...
Yeah, quickly, Dr. Schulman, thank you. But what I also wanted to point out that for left bundle specifically, the choice of stress test should be vasodilator with perfusion.
That is correct.
Not only exercise, and the underlying mechanism from what I read and understood prior is that even exercise with imaging is because of the desynchrony, it's not going to be helpful. It's going to be abnormal anyway. That's why we should use another mechanism to induce ischemia, like vasodilator and steal mechanism, to try to find out if there is any ischemia.
That is correct. I thought I put a slide in here. I do have a slide on that. I may not get to it, but you're absolutely right, and Mansour is absolutely right. So it turns out that in the presence of a left bundle branch block, there's dysynchronous contraction, and therefore things that use imbalance between different regions of the myocardium may create a false positive falsely abnormal reduced perfusion in the septum because contraction occurs, goes into diastole, and diastole is normally when coronary perfusion occurs. And if you reduce diastolic perfusion, you're going to look like there's a abnormal region in the left side, in the septal region. So Mansoor is absolutely correct. We generally recommend a vasodilator stress test for patients with a left bundle branch block. The other point is you got to be, if you're asking a different question, if a patient has a left bundle and you want to see what their heart rate response to exercise is, then you need to do a new stress test. I've seen some cardiologists do both testing. If you can figure out a way not to avoid additional tests, that would be useful. But good point, Mansoor. Exactly correct.
Yes, just to add on Dr. Schulman's the point, I think yes. So pharmacological nuclear stress test is preferred to exercise. It's not absolutely. I think one is they have both have a very similar, very high sensitivity, but the specificity with the pharmacological is remained at 80%, but the exercise nuclear for left bundle dropped down to 50%. So that is the reason the vasodilator is preferred. And the other thing, it was a concern because of exercise increased the heart rate that will mess up the increased false positivity. There was a study, I think they talked about, we use a percenting a lot more. That does not increase the heart rate that much, but Lex scan we're using now actually can increase the heart rate up to 40%. There was a question about that. Would that heart rate increase actually increase the false positivity? I think the study shows that there's no definitive answer. Therefore, Lex scan nuclear stress test is still preferred in the left bundle.
Right. And then there has been some discussion of a dobutamine stress echo that's probably better than some of the others, but we don't use that often either. Okay, so we're getting toward the end. So these are the types of stress testing. Exercise ECG, I think you're familiar with this. We do exercise ECG. We do an exercise nuclear stress test now we're using sestimibie. We also use exercise echo, and we use dobutamine echo or myocardial perfusion imaging. And then I'm not going to talk about cardiopulmonary stress testing. I think you'll probably talk about that later on sometime other lecture in the year with talking about heart failure. So a couple more things about ECG abnormalities. Sensitivity and specificity for standard ECG, roughly 60 to 70% for sensitivity, 90% for specificity. V4 through V6 are the most sensitive to detect ischemia. Horizontal ST depression is considered diagnostic. We talked about ST elevation in AVR and V1. We talked about, we did talk about this. We talked about frequent ectopy with stress, with ischemia can impart a worse prognosis, and exercise-induced left bundle can indicate an abnormal or adverse prognosis. So this is a, let's see, I think I'm going to, oh yeah, so here's a patient with baseline ECG, a 40-year-old man with chest pain, and then with stress, he developed a, no, I think this is another patient, but this patient, actually, we've seen a few of these, some recently developed heart block with exercise, and that could be a function of AV nodal conduction disease or sinus node disease. So this is a patient who didn't have ischemia, but had conduction disease manifest on stress testing. So some things to be cautioned about: if the blood pressure drops by 10% from baseline with evidence of ischemia, that's an indication to stop the testing. If the patient has moderate to severe angina, if the patient has CNS symptoms such as ataxia, dizziness, or near syncope, if the patient looks like crap, sorry my French here, poor perfusion, ECG, that's probably racist. I'm sorry to anybody as a Frenchman. Looks like, looks bad, sign of poor perfusion, cyanosis. If you don't have ECG monitoring, you got to stop the test and rehook up the patient. If the patient says he wants to stop or she wants to stop, you got to stop it. Patient has sustained VT, and if it has ST elevation in AVR or by more, or in any other lead by more than a millimeter, you need to stop the test. That's concerning. Then there's other things that are a relative indication, like if a patient drops the blood pressure a little bit without signs of ischemia, you probably can go ahead. It could be patient relaxing, getting less anxious on the test. Just ST segment depression alone, if the patient looks pretty good. I actually have about 2 millimeters of ST depression. I've had it since I was 20 years old and never had any chest pain. So that alone would not be an indication for stopping. Other arrhythmias, SVT, frequent PVCs, you have to make a judgment call. Fatigue, dyspnea, wheezing, leg cramps, generally stop it. And if the patient has a hypertensive response over 230, we do generally stop the stress test after 230. Now, I'm going to just briefly, we're not going to have time to stress echo, but I am going to show you a couple of nuclear stress tests. So what this is a myocardial perfusion imaging at a patient. And basically what you're doing is you're doing a resting injection and a post-stress injection. So this is the resting injection below. It's compared head to head. These are slices of myocardium in the horizontal plane, in the vertical plane, and in the sort of the lateral plane. So you see it in 3 orthogonal, 3 perpendicular planes, and this is what I like to call the sort of like a bagel view. Looks like a slice of bagel. And what you see here is that you see relative perfusion of the myocardium. So you look at this is the apex, and this is the base of the heart near the valve. You probably generally ignore some of these extreme far left and far right imaging, because this one is sort of like cutting off the tip of the apex of the heart. You can not exactly line it up perfectly, and this goes through the valve plane, so that's not helpful. So what you're looking at is these images in the middle, and you look for uniform perfusion in the anterior wall, lateral wall, inferior wall, and septal wall. You look at that at stress and at rest. And normally at stress, the myocardium looks like it shrinks a little bit, and the uniformity of distribution of myocardial perfusion imaging is well, the imaging is uniform. And the same thing here in a second orthogonal plane. This is the anterior wall and the inferior wall in the apex, and this is the third plane where you have the lateral wall and the septum. Sometimes you see a little bit of right ventricle on the side here. Now, this would be an abnormal test. You can see pretty straightforward. This is the lateral wall here at stress, and this is the inferior wall. So you see it looks like somebody took a bite out of this bagel. So you have a inferolateral wall motion abnormality that gets back to normal at rest. These are relative perfusion of the regions of myocardium. It's not absolute because it's normalized for the maximal perfusion area. So it allows you to look at differences between various regions of the myocardium. And you see here in the inferior wall here during stress, you see inferior wall and a little bit in the lateral wall here. You see lateral wall hypoperfusion. So bottom line here is this patient has mostly inferior reversible perfusion defect. And in this case, the region of the perfusion defect can predict which artery is involved. And there you see it close up, inferolateral, and this is with stress, and this is at rest. You see a normal at rest, normal uniform perfusion, and this is a rest perfusion defect. So, John, I think, and again, you can look at that. I think it's 9 o'clock, and people have to go. I can finish this at some other time in the future, or I think I covered most of the stuff, but there's some more to cover. But I think it's after 9, so I think we'll I mean, I'm happy to go on, but I think we probably better stop here.
Yeah,
Whatever you
we can
like.
stop here, Dr. Schulman, and then we can maybe arrange another session
Sure.
with you moving forward.
Sure. I'll show you the joke here. So if you don't follow these guidelines, if you don't follow the end, you see what happens if you don't follow these guidelines. And then finally, if you think that traditional stress testing is too risky, how about watching CNN for an hour or Fox News for an hour?
I just have one comment, Dr. Schulman, about the stress tests.
Yes.
In the exercise stress test, the SVTs, AFibs, flutters usually do not indicate ischemia because the upper chambers are really involved in ischemic driven arrhythmias, and it's not an indication that it's a positive stress test. That's my understanding. It may indicate an underlying bypass circuit or a predisposition to SVTs, but not necessarily ischemia.
Yes, that's a very good point. Thank you for bringing that up. Very good point. It's not an indication of, well, the reason we would stop the test is it could be dangerous to exercise, vasodilate in the setting of an SVT at 180 beats per minute. That's the reason for it. But your point is exactly correct, that it does not necessarily indicate ischemic heart disease. And the counterpoint to what you're saying, which is very important, is that patients have an episode of SVT or AFib, and doctors say, "Oh, we got to rule out ischemia." Very unlikely to be an ischemic etiology of atrial fibrillation. It's usually either an underlying substrate problem or other conditions. So thanks for bringing that up. Okay, well, thanks very much.
Thank you very much.
Enjoy your day. I'll be around.